the current health crisis and how critical it is to have a workforce that is resilient and robust. And so what I'm going to talk a bit about today is a little bit about how do we plan for a good workforce, and then give some examples of some palliative care education and training initiatives. So the webinar will take some time to go through some of those issues, and then if you could hold questions, and we will be very happy to take questions later on. Requesting remote control of my content. I'll approve that. Okay, thank you. Just going down. So as I said, I think before we talk about education and training, we need to think about our workforce as a whole, because I've always had the view that planning for education means that we need to really understand what our workforce needs to look like, because our education should be about preparing people for the capabilities that they need to provide care. Can I just ask people to pop on mute, if that's okay? There's just a little bit of noise in the background. It would be great if you could. That would be great if people could go on mute. Thank you. So thinking about that process of defining what is it that the workforce needs to look like, to use that to inform our education and training programs. It's also important to think about the whole of workforce, and to think about all of the different parts of the workforce, because we all work together as teams. And as part of that, it may be that building our education programs need to take into account how we might work with others. So I'll just check if people could actually, as I said, go on mute if that's possible, to help with the noise. So this diagram is really trying to sort of say that, you know, when we think about our workforce, we do have our voluntary workforce, right up through to our regulated workforce, and our specialist workforce. But it's important that we think about all of those providers when we're planning to build a workforce strategy, particularly in palliative care. This next diagram it takes it a little bit further, and this is from Palliative Care Australia, where we also thought about how our workforce needs to sorry, I just asked if people could go on mute, that would be great. How our workforce needs to be flexible. So we might just go back to the previous slide. So really what this is saying is the bottom part of the triangle here is where we have people whose needs in palliative care are straightforward and predictable. And they may need primary care services, they may need generalist services, but perhaps not as much specialist services. Whereas at the top of the diagram, we have people, some of our patients whose needs are complex and persistent, and that's where we need a specialist workforce. So what this diagram is again trying to say is that not everyone needs the same type of training and education in palliative care. It's saying that probably everyone needs some training and education, but for some people though, we do need specialists who have that advanced level. So it's again really trying to say that it's not one size fits all, that we do need to tailor our education and training to the sorts of workforce models that are needed. And here's just also trying to say the other thing when we're thinking about planning our education and training is not just about our whole of workforce, but it's also planning for what is the environment like and what are the sorts of capabilities that our health professionals may need. So this is, for example, some data from Australia showing about the different populations. And really what it's saying is, like many of our populations, we have an ageing population. So our workforce in palliative care needs to be able to care for people. And also, thank you, that's good. And also it's saying that, well, when we look at that older group of people, the people over 65, many of them have more than one chronic condition. So if we understand what does our workforce then need to be prepared to do? So as I said, we start by sort of understanding our whole of workforce. We also then need to understand what does our populations and our communities need in that workforce. And clearly this type of demographic data is telling us that we probably need to be preparing our workforce to deal with people with complex chronic conditions a little bit more than what we currently have been. But there are some other factors which I think also are influencing palliative care education that are important to think about as you're going about planning your workforce and designing your education. And I categorise these into factors at the population level. So we've already just looked at demographic changes and patterns of health and illness. But it also may be things about the diversity in our populations or disparities. Some of those things are important for us to take into account as we plan education. At the systems level, there's lots of trends happening that also influence how we deal with education. And it's things like the much greater move to personalised care, technology, the greater complexity in our health systems. And then, of course, it's also thinking about our learners and how our learners also are actually changing. So we've got learners and health professionals who are much more digitally competent than what they ever have been, that they are much more diverse in many ways, and they're much more mobile. And with all of those factors, when we're thinking about planning our education at population, systems and learner level, we need to think about that to make sure that we're designing our education programs to take account of those trends. So as I said, I've been talking about we need to think about a whole of workforce. We need to think about what's changing in our patients, what's changing in our environment, and what's changing amongst our health professional workforce. I just wanted to take you through some of the examples of what we're doing to try and be responsive to some of those changes. And this is some examples of work that's part of the Palliative Care Education and Training Collaborative funded by the Australian Government, where we have a number of different projects that's designed to take that whole of workforce approach, that's designed to really be very flexible in terms of supporting a specialist workforce as well as a generalist workforce. And here's a model where we try and understand what that is. So basically you'll see in this model in the centre there, and I think really what we always try and do with our education is that it's always about preparing health professionals that is centred around meeting the needs of our patients. So education can't be done without that understanding of the needs of our communities and populations. And then, as I said, what we've got is on the left-hand side is what we call our essential workforce. So that's saying that pretty much everyone, whether they be in general practice, whether they be working in an intensive care unit, everyone needs some skills in palliative care, and that's our essential workforce. And on the right side, though, there's this other group who are our specialist workforce, who really are people who are working predominantly with our in palliative care specialist settings or hospice settings. You'll note that around this diagram, we note that this varies. We need to think about this as interprofessional practice because disciplines don't work in isolation. And so when we're planning our education, ideally we're taking account of the role of different disciplines within a team. And we also need to obviously take on board, though, our discipline-specific and professional standards. So what this diagram is just really saying, this is a model that we have worked with to try and guide and inform our programs. And essentially what we're trying to say here is that we develop programs that are across the board, some for essential workforce, some that are more targeted at specialist. And we focus around these other issues of interprofessional practice and dealing with individual issues. We've done this by, at the same time, as part of our collaborative, doing what I said before, thinking about that, what's our whole of workforce need to be? And so part of that is assessing the demand and supply going forward. Once we understand that demand, what does our population need? We can then define, well, what are the capabilities that those different components of the workforce need? What are the skills and abilities that they need? And then we're also in our workforce action plan as part of this project doing an environmental scan to try and understand how do we make available as many different learning opportunities that exist out there as possible. So this is again just outlining some of the approaches that we're taking. But let me talk you through two specific examples of education programs that may be of interest to you that illustrate how we're trying to take a whole of workforce approach. And the first of these is our palliative care curriculum for undergraduates project. And again, this is a national project funded by by the Australian government, where we're trying to actually say that every health professional, no matter what discipline, needs to have some training and education in palliative care. So how have we done this? Well, we started off by doing some research and development to understand, well, what are the graduate capabilities? We then did some pilot testing, and we're now in a national rollout and ongoing innovation stage. And I'll take you through what some of those phases have been like. So let's start with that first phase. How did we come up with a national curriculum that we're now rolling out that is being taken up nationally? Well, the first thing we did was we looked at scoping of existing curricula. What was some examples of best practice? We did some surveys, we did some focus groups, and we did a review of the literature. So we developed an evidence base to inform the resources which we've developed to be part of our curriculum. What did we find as some of that research? And I'm sure that this would probably be fairly similar to what many of you would find if you did research in your own settings. And we're happy to share some of these research tools if people are interested as well. But essentially, one of the questions we looked at in our curriculum audit was how much palliative care was covered, how much content. And you'll see there that in some areas, there was, like in allied health, when we did this survey a few years ago, the purple bar there is where there was not at all, in many of our allied health disciplines, there was no palliative care at all. Whereas, of course, in other disciplines, we had much greater, at least to a minor or to a moderate degree in nursing and medicine. Today, a few years on, after reintroducing our palliative care curriculum, and I'll show you some data in a minute, we've actually increased that considerably, in that many of our courses now are really including palliative care to a very high degree. We also looked at some of the barriers that people told us, and I'm sure this is very similar to you. Lack of time, crowded curriculum, limited opportunity to integrate theory and practice. There was few placement opportunities. The teachers didn't know much about palliative care. It wasn't viewed as a priority, and that this access to specialist staff was sometimes challenging. So they were some barriers which we had to deal with if we're integrating palliative care in undergraduate courses. And we'll talk a bit about how we've done that. We then actually did some surveys across nursing, medicine and allied health about what were the sorts of skills that people felt were important. And you'll see some of the most, the top ranking sort of things pretty much across many of the disciplines were around communication, understanding the philosophy of palliative care, clinical skills varied. There was also some comment about individual attributes of individuals, about sort of being able to really embrace and understand that philosophy of palliative care. And what we were surprised about was how common many of those issues were across the disciplines, which gave us confidence that actually developing some core material which could be tailored to disciplines that would be useful. And so here, for example, is what was the top 5 areas, the most important topics across the different disciplines. And you'll see in medicine and nursing, not surprisingly, it was around communication, pain, and dealing with symptoms. Whereas in the allied health areas, it was about communication and psychological support, loss and grief. So a little bit more of the psychosocial issues than in nursing and medicine. But again, that gave us some clues as to what sorts of things we needed to embed in our curriculum. Again, these were some of the barriers about that, you know, which I've highlighted before, but some different issues came up in our surveys about, you know, reminding us about the stigma and fear of palliative care still. That was a factor that came up in some areas. So lots of different sorts of concerns that people had, that if we're going to embed palliative care, we need to, we really do need to address these barriers, or else we're not going to be successful. Again, when we did some focus groups, common things which came out was about these sorts of things, about being able to respond to people across the trajectory, understanding the changing sort of nature of chronic disease and the burden of disease, and how that, what the implications that had for different goals of care. Some things around emphasising the principles of clinical management and about diversity and person-centred focus. So that was, you know, so again, some good clues as to what sorts of things needed to guide and inform our curriculum. We also asked in the focus groups, though, not just about what should go in the curriculum, but we did ask about, well, how should we include it? And we had got some very good information as part of our research activity. And there was a very clear view that we needed to integrate this throughout, as well as have it as a distinct subject. It needed to be explicit, but nonetheless integrated and not separate. That we needed to be very flexible and have cost-effective learning strategies so that in a busy curriculum, people would include it. There was a lot of comment about the types of learning and teaching strategies and the importance of experiential approaches, and a lot of comment about learning activities that help develop people's awareness, their personal awareness of what they bring to their interactions with patients who are dying. So some really good clues about how the types of learning approaches that would be important. So we used all of that research early on to develop a set of graduate capabilities, some statements and principles about what should all graduates be able to demonstrate, and what are some principles for how we might include that in our curricula across all disciplines. And we developed a set of learning resources and a set of recommended strategies for implementation. And these were, you know, as I said, we developed into this document called some principles, and I've got the links and websites at the end of this presentation, because all of this is freely available and able to be tailored to your own settings. In terms of the graduate capabilities, though, which really underpin all of our learning resources, there were really 4 main graduate capabilities that everyone consistently said that they wanted us to really focus on. And they were around communication, appreciation and respect for diversity and how people respond, being able to assess needs and manage those needs, and reflection and self-evaluation, with 4 core capabilities. And obviously there's a lot in all of that, but at a high level, they were the 4 capabilities. And so our task then, after defining those and getting agreement, was to actually say, well, how do we develop those excellent communication skills in dealing with loss and grief and change over time, etc.? How do we develop the skills in symptom assessment and management across different sorts of patient needs and conditions? And how do we develop those ability for critical self-reflection and evaluation? So we then went on to develop a suite of learning resources, which were very much around, here are some tools and learning activities that can help you to develop those capabilities in your curriculum. And they are freely available, as I said, on a website. So in a sense, what we developed was 4 core modules and some supporting modules that we embedded and we used that experiential notion and that case-based approach, where we tried to reflect the differing examples of differing patient needs and different practice settings, different illness conditions, different socio-cultural context. We made sure that they were all evidence-based in what we were doing, and we made sure that we included multidisciplinary perspectives. In the learning resources, we built it around patient journeys. We had some clinical decision-making vignettes and activities. We had evidence reviews, reflective activities, expert opinions and modelling. And as you see, a range of different types of learning approaches. And I think that's really important, that we aim to make these learning approaches ways in which they were truly helping people to reflect on how they thought about providing palliative care. And this is what the modules look like. As I said, we had modules around the principles of palliative care, modules around communication, around assessment and management of common symptoms, and a module around optimising function. We also had some specific focus topics, which are around multidisciplinary approaches, around caring for Aboriginal and Torres Strait Islander communities, around caring for children, and around culture-centred care. All important focus topics. So we've been using and rolling those out now for a number of years. And here's just a little bit of data to show you, and this is data from August last year, of where we're at across the country, across different disciplines. And you'll see that the blue bar is the number of courses. So we know in Australia we have 208 courses in the health professions across all of those different disciplines. The blue part of the bars are the number of people implementing our curriculum. The reddish bar is the number of people who are reviewing. And then the green is the number of people who aren't using at this point. So you'll see there overall, the data at the bottom, 66% of our curriculum, of all of our health professions, are implementing our curriculum to some extent. 19% are reviewing, and we have 15% who are not using. And we're still working with those sites. But you'll also note the differences across disciplines. And you'll see that nursing and medicine in particular are really well advanced, being, I suppose, the having embedded palliative care for a lot longer than some of the allied health disciplines. But the allied health disciplines are really picking up, and you'll note, for example, OT, occupational therapy. You'll note the pharmacists really trying to embed this, and you'll note some of our paramedics also trying to embed. So we've really come a long way. We're also, so this was actually, we designed this for university-based courses, but we've now adapted it, and we have a toolkit that we've developed for our registered training organisations who are our non-university, so our pre-university programs. So those that prepare diploma level programs for enrolled nurses and getting really good traction. And we're coming soon, we're in the process of developing a package which is specifically in our registered training organisations for our care workers or assistants in nursing level. So, you know, I think my point about this is that it is possible to achieve a high uptake of palliative care in undergraduate courses if we go about it in an evidence-based way, if we truly provide some useful and easy resources to help people who are not confident. And we've also got a whole range of data around our graduates who are finding these materials very effective. So I'm just going to go on and talk a little bit about another program just for a few minutes and then leave some time for questions. So that's our undergraduate courses. But as I said, when we're thinking about a whole of workforce approach, we also run programs which are about continuing professional development. And this is our program of experience in the palliative approach, which some of you may have heard about, again, funded through the department, our Commonwealth Australian Government. And the aim of this is actually to sort of build the capacity of health professionals who are non-specialists. So our GPs, our nurses who work in non-specialist settings, our allied health professionals who work in non-specialist settings. And our aim here is to skill them up, not to be specialists, but to skill them up to be more confident, to provide that fundamental, that essential level of care, and to work in partnership with our specialist workforce, taking that whole of workforce approach. So this PEPA program, again, we're using some of the same sorts of principles as we did with our undergraduate work, about being centred around the learner, centred around our patients and communities, about cultural relevance, collaborative, flexible, etc., evidence-based. Same sorts of principles. In our PEPA program, we have two main types of activities. One is a supervised clinical placement, where GPs, nurses in primary care, we provide them with up to a week in a specialist palliative care setting with a mentor, where it's basically an immersion experience. And the GPs or whoever go back to their practice with a much better understanding of the principles, much greater confidence, and much greater ability to know who to contact when they need help and who to refer to. We also have some workshops which are associated with these programs, which are around pre and post support, using very strong educational strategies about reinforcement of learning and transfer of learning into the workplace. So these are some of our workshops, as I said, a series of different activities which are really around reinforcing learning back into the workplace, about core modules. But in addition to that, we also want to have quality experiences. We all know that when you've got people on clinical placements, students or offering professional development for others, that part of their learning outcomes is very dependent upon the environment. So we've developed some other mentoring workshops, and that's really about it for our specialists to actually say, well, we can help you build your skills to be good mentors, good clinical teaching skills, so that you can support people when they're undertaking their placement, or students for that matter. And alongside all of this, we've got a range of different learning guides which are available for people to be self-directed in their learning. So again, using multiple types of good learning pedagogical strategies which focus around encouraging self-direction, good mentorship, experiential learning, and all of those different sorts of things, and recognising that learning is an ongoing, a lifelong process. So our data from this, and this just shows the number of people who've done some of our programs, our PEPA placements, and you'll see over the years, we've been running this for quite a while now, and on average per year, we have, up to now 350 health professionals across all disciplines undertaking some sort of PEPA placement per year. Really trying to expose our non-specialists to being much more confident to work with our specialist providers. It's been an excellent model. And our workshops is on the right side there, again, huge numbers. And our participants, the outcomes consistently, they tell us it's about they're feeling more confident, they know who to refer to. One of the other important things as part of PEPA that we do is we have a specific dedicated focus on our Indigenous communities in Australia, which is a particularly important community that we know the outcomes for our Indigenous populations are poorer in Australia, and that we need to have the whole meaning of death and dying and the whole approach to palliative care needs to be tailored in different ways. And so we have developed a specific tailored model for our Indigenous healthcare providers, Indigenous healthcare workers, that's very much focused on Indigenous knowledges and their understanding of the meaning of palliative care. And we've partnered with our Indigenous organisations to make sure, and we've developed a whole range of resources, and even just to sort of show you a lot of the artwork there, the artwork we commissioned because within the Indigenous populations, the artwork was especially important around how communication around these issues. And you'll see that even in our language we were using, because in our some of our Indigenous populations, the words death and dying are not spoken, or terminal illness, or we've actually worked with them to get the right language and to try and make it accessible so that our Indigenous health workers would be part of the program. So we talk about, for example, do you care for someone who's got a chronic or advanced illness and unlikely to get better? And that's actually been, by working with our Indigenous communities, that's actually been a really good way in which we've been able to get people to be part of. And we tailored the program differently so that it was culturally appropriate. And as I said, our success factors, and I'm talking here about our Indigenous, but I imagine in your communities, you've got specific populations, again, where this is around some of the principles of cultural respect, where it was really about recognising, acknowledging and partnering. It was really about having the activities led by the Indigenous health professions and community leaders who are a key part of that program. That Indigenous cultures and knowledges are embedded throughout, and that we're engaging with Indigenous communication and promotion networks, and that all the way through we're using appropriate, culturally appropriate learning activities. And in the Indigenous communities, a lot of that's about storytelling or what they call yarning, and about support for our non-Indigenous health workforce. So the non-Indigenous people, so that, you know, that we are much more culturally safe. We provide much more culturally safe environments for when we're caring for people, Aboriginal and Torres Strait Islander people who are dying. So the outcomes, again, we've had extensive engagement, and we actually employ a specific Aboriginal and Torres Strait Islander staff to deliver PEPA. And, you know, with the uptake by the community has been extraordinary, given that the health outcomes for this group, and they've got so many demands on their time, they've really appreciated that. So those are just two examples, and I'm just going to show these last couple of slides to show you where you might find some other approaches. So essentially, as I said, we've been talking about a whole of workforce approach. So this is a website that's on the Care Search Hub, the education section of Care Search, which is an Australian website, where basically we take you through this whole of workforce. So if you click on, you know, those that whole of workforce, it'll take you through to the model. And then we go down and we sort of say, we've designed different portals, different ways to get into this website. And the second, the middle part there is say, I'm part of the health workforce and I want to find something that's relevant to my learning. And we take you through, well, what are some of the formal qualifications? What are some of the web-based learning? What are some of the short courses? And we try and keep that up to date. And the last bit there is, though, I'm an educator or a manager and I want to support learning. And again, we talk here about how to apply our framework, how to create and design activities, how to develop teaching and learning skills, etc. So you'll see that we've tried to provide those two examples in the context of, and this is an example of about applying the whole of workforce framework that we've developed. So here are just two links to, you know, the screenshots of the main pages of our palliative care curriculum and our PEPA website. Both are freely available and able to be adapted and contextualised to your own environments. You know, just we fortunately, because they're being funded by the government, our brief was to make sure that they really are used and are helping to develop our workforce, our whole of workforce, as I said, to really be addressing the current needs of our communities. So that's just a couple of ideas of our experience of developing programs. I do think that they're getting the right educational strategies is critical to addressing the complex types of capabilities that palliative care providers need. So, you know, that's part of what we've aimed to do through these programs as well. So I might stop there, and that gives us plenty of time for questions or sharing or suggestions. So I think now, do I get into the question?
Please stop sharing.
Stop sharing, yep. Great, and I can see in the chat box any questions. So we've muted I'll just go down and see. Okay, so please, would anyone like to type in any questions or put their hand up and actually even ask questions? We can manage if people, we can do that one at a time.
Anyone would like to ask question, you may unmute your microphone and directly call, or you can type your question.
Hello.
Yes. Hello.
Yeah, I am Fazlanur Biswas. I am from Bangladesh. I am working in as a clinical pharmacist in oncology department.
Yes.
And previously I have been working in palliative care for last 8 years.
Yes.
My question is that if is it possible to collaborate research with your organization, and like I'm working in oncology, so is there any collaborative research option?
Yes. Look, I think we're very happy to share some of our tools and some of our protocols for people, particularly around some of that beginning needs-based work. What is it that our communities need? And then some of those sort of identification of needs. But then we've also got some great outcomes tools. So we've developed some tools which really help you to assess learning outcomes from different programs. And yes, we're very happy to share some of those, and some of that is actually up on our website, but very happy for you to just email me, and I can put you in touch with our research officers who can share some of that information.
Because in my new workplace, we are planning to open a palliative care unit. So
Yes.
that is why it is. That is why my question is that, like, is that. So I like. So I am happy to know that you are. You agree with me that there are options to work together.
Yes. Yes.
And
Yes.
uh,
Please just be in touch, and we can assist where we can. Yep.
Okay. And is there any like I saw that there are placement and workshop opportunities. So if I applied for any placement or any training, so for that I need to go the website and then I should apply, or
Yeah,
okay, okay.
unfortunately, at the moment, the government only allows
Yeah.
us to use the placements for people in the Australian health workforce, but certainly some of our online tools, our online workshops, our mentoring guides, are very happy to share those. But unfortunately, the placements are because they're funded by the Australian government, are only available for the health workforce in Australia at this point. But
Yeah.
I think other exchange programs, and that's something that APHN is very good at, is also, looking at opportunities to sort of see where other exchanges might occur for similar sorts of outcomes, and perhaps that's something we could ask APHN to sort of continue to support as well. I think experiential placements are so valuable.
Thank you.
So a couple of other questions have popped up on been typed in here. Got a question from Jeffrey who asks, how often do we do our workshops? Well, our workshops are all ongoing. So we each year we have a planned number that we aim to deliver, and we do them all around the country, both in regional areas as well as in major cities, and so they're ongoing. Some of those workshops are just one-off programs, but typically we try and link the workshops with other activities. So typically we try and link a workshop prior to someone doing a placement so that they're well prepared, for example. We've got another question which asks, we'd like to ask if there's been special empowerment education program online for healthcare professionals about palliative care challenges during this time of COVID. Oh, what a good question. Look, I think that everybody is really scrambling to try and provide the support that's needed across all of our health systems. I'm not aware of anything that's specifically targeted to palliative care. I am aware that I know Palliative Care Australia has stood up a working group to try and really put out information and resources as quickly as we can. But I'm not sure if anybody else is aware. But again, that's perhaps something that we could ask APHN to sort of look at to see if there's anything. Because I agree, I think, the role of our palliative care workforce is so important at this time, isn't it? We've got another question. Is there evidence suggesting about the credit hours of palliative care education correlate with better learning outcomes? Also, what's your experience with the tools or other ways of evaluation? Again, a really, really good question. In fact, I'm not aware of any evidence around the number of hours, but I am aware that some of the evidence does talk about that at least a structured program that particularly uses experiential activities does achieve better outcomes. So, for example, there was we've done some reviews of the literature where some of the graduate surveys, for example, where they've gone a year out, 12 months out of someone graduating, and they've asked graduates, you know, what do you remember about your palliative care education in your training? And those who actually can remember undertaking good quality experiences often report better outcomes in terms of the quality. There has been a number of trials of different, but usually those trials are in very, not necessarily very generalisable, because they're done with small groups, often volunteers, not across whole courses and curricula. But I think the evidence, probably the strongest bit of evidence in palliative care education relates more not just to about the amount of time, but relates more to the way in which we teach. So about the types of learning activities and the quality of the learning activities. And in terms of tools, yes, there are some very good tools which are survey-based tools, which focus on issues about self-efficacy or confidence with providing palliative care. And typically those confidence tools assess both knowledge, attitudes and skills, so across all of those domains, but they are only self-report. Sadly, many of the knowledge tools that assess palliative care education outcomes are not very good. They often don't go across disciplines and are not very tailored to context. So I think some of the better tools that are being used, that are more commonly used today, are some of those tools, self-report tools, which are around self-efficacy. Having said that, though, is increasing, and one of the other pieces of work that we did with our palliative care curriculum was we developed a simulation module. And so a guide, a simulation case study, so that our educators who have good simulation facilities can use that case study. And with that, we did develop some more performance and clinical performance assessment tools. So because self-report is obviously not the same as actually how one performs in their practice. So self-report is often all we can do because that's all we have access to when we're dealing with research. But in practice, a really good clinical performance assessment tool and observation of practice is good. And we've developed some guidance around that in the context of when people are doing simulations. So yes, there's some, and again, that's on our website as well. Any other questions? No other questions? Would anyone like to, just in the last minute, just share any or make any comments about any of the issues that have been raised, or
Professor, one more question.
Yes, I can see another question. Grateful to connect with the working group in Australia, synthesising and getting out key during COVID. I will ask our palliative care, that working group, we've got another teleconference happening in the next few days. I will definitely ask if they can share that with you, as being, Palliative Care Australia is a member of APHN, and I know would be very pleased to share any insights. Yes, and I agree with you, especially on that topic of ethical decision making. I think, that's just going to be such a challenging issue, isn't it? So yes, I would be, I mean, some of the things we've been talking about even in trying preparedness for going forward. Over in Australia anyway, you know, our anticipated preparedness probably getting it to a peak in mid-April is what they're thinking about is how do we also equip our primary care providers, the non-specialists to have access to medicines that they need to and be confident to be able to use those. There's so many different issues that we need to deal with. Any other comments or questions? No, okay. Well, look, I want to thank you very much for joining and thank you for those very important questions. I do really wish you all the best with your own education and training activities. I think, as I think, you know, the last questions have been asking, we're facing a very extraordinary time across the world, and I think it's just so important that the quality of people at quality of end of life care. We continue to see that as so important over the coming months. This is where education and building a responsive workforce is so critical. So I wish you well, and thank you for your for listening and being part of this webinar. Bye.
Bye-bye.
Thank you.